So to start off the afternoon, we have a presentation on parent depression and stress associated with newborn screening for rare onset disorders. Please welcome Nicole Kelly from the Children's Hospital at Montefiore.
Good afternoon, everyone. For having me. I'm Nicole Kelly, and I am too hard for the mic, as he says. Go closer to them. Oh, that's what you said. All right. I'm the program manager for Screen Plus, the pilot newborn screening study conducted out of the Children's Hospital at Montefiore, led by Dr. Melissa Wasserstein. Recently, today I'm here to talk about parental stress and depression associated with newborn screening for rare and variable onset conditions. So, as a roadmap to the presentation, I will first describe why is it important that we understand the implications of screening on parents and society as newborn screening expands. I'm also going to talk about the arguments for and against screening for late and variable onset conditions, what we know about them, and how did we go about developing the survey, collecting the data, the results we found, and where we go from here. So with the evolution of newborn screening, we're able to detect more conditions. And a lot of these conditions are complex, and they have variable onset, early, late, in between, or uncertain. And with that, it really starts to fall outside of the traditional newborn screening paradigm. The Secretary Advisory Committee, sorry, I'm nervous, takes into account the likelihood of net benefit when assessing conditions for the RUSP. Miranda, thank you this morning for going over that. The recommended universal screening panel. So with net benefit, it has traditionally been defined as clinical outcomes, but there is increasingly an argument that we need to understand the social benefits as well as the harms of screening for families, and it needs to be considered as we move forward. Lastly, we lack the objective data to do so. I missed a little thing. These are the Wilson and Younger criteria, which they're the traditional paradigm and scope back in the 60s that were mapped out for newborn screening. So here we have another scale and weight. And here what we're looking at is, should we be screening newborns for later onset conditions? And on the benefit side, these benefits really map, again, to benefits in clinical outcomes, right? So even if it's later onset, these disorders, they're progressive and disabling without treatment. So newborn screening will allow us to identify and track over time and intervene when it is the right time. Rare genetic disorders have a diagnostic odyssey. Newborn screening can stop that. It permits informed decisions around education, employment, your health, and it allows for reproductive and family planning. On the risk side of things, it's a little harder to quantify and measure. So many and most of the professional societies, they historically recommend against screening infants for later onset conditions, suggesting that testing can be deferred until adulthood, unless there is a treatment that can be administered in childhood that can reduce the morbidity and mortality. The difficulty is when receiving results for uncertain and phenotypically variable conditions, it can result in an increased psychological burden for parents who must live with uncertainty regarding if or when the child may become sick. And it potentially is turning families into patients in waiting, creating the vulnerable child, and a loss of autonomy, and may also impact insurability. Pilot newborn screenings, or the programs, really allow us an opportunity to collect vital data that we need to be able to assess and understand what these implications really are. So we did that. Years ago, we ran between 2013 and 2017, we ran a pilot newborn screening study for 5 lysosomal storage disorders with our colleagues at the Department of Health. Joe Arsini is here today. Across 5 high birth rate, ethnically diverse hospital systems in New York City, and you can see where they are on the right-hand side. We screened over 65,000 newborns for these conditions, in addition to the routine newborn screening. We also implemented an ethical, legal, and social implication survey, so ELSI, to understand what is happening, what are these issues, and that took place in 2019. And this is our survey. We sought to compare the psychological outcomes of parents of children with a range of newborn screening experiences, with a particular focus on the lysosomal storage disorders and ALD. We feel that these are representative disorders of complex presentations. Right now, and really, currently we cannot screen, or as we screen, we can't differentiate with an abnormal result if early or late or where it may fall. So it's not predictive all the time. So parents were eligible if they spoke English or Spanish, and they had at least one child born in the United States between 2013 and 2018. We recruited in a tiered approach, so those who were identified through the pilot newborn screening study were sent letters invited to take these surveys. We also invited providers from our pediatric clinics at CHAM, the Children's Hospital of Montefiore, inherited metabolic disease referral centers across the United States, administrators of newborn screening websites, and patient advocacy groups. So this cross-sectional online survey was developed and included about 70 questions across the 6 domains you see at the top. It took approximately 20 to 30 minutes to complete. For this talk, we were looking at parental stress and depression, and stress was measured by the parental stress scale, and parent depression was measured by the subscale of a HADS, so Hospital Anxiety and Depression Scale. For data analysis, what we did is the parents were categorized into one of 4 groups based on their child's newborn screening result or their disease diagnosis. And you can see the 4 groups. So we have our LSD newborn screening diagnosis group. That is a parent with at least one child with an LSD or ALD identified through newborn screening. The next group is the LSD other group. So same, a parent with at least one child, but diagnosed clinically. We also have a group of the RUSP newborn screening diagnosis, so those who are diagnosed on a routine RUSP disorder through newborn screening. And our control group was no diagnosis, so no disease and a normal newborn screen. We ran bivariate tests to assess the relationship between the parent group and sociodemographic variables we collected, and then ran binary logistic regressions. So we estimate the relationship between the parent group and the odds of that group having depression, considerable depression, or a high parental stress scale when we control for the variables that we saw in the sociodemographic side as being considered associated. So there may be an impact for there. So overall, 174 participants responded to our survey, and we're able to bucket them into these groups that we talked about, and you can see them on the right-hand side. Most parents reported currently living in California, New York, Texas, and Pennsylvania. The parents were mainly mothers, reported that they were married, living with a partner, employed full or part-time, had received a bachelor's degree or higher, self-identified as white, and had an annual income of over $50,000. The mean age was 30. All right, so what did we find? So when we were comparing the parents of children diagnosed with the same disorders, so the LSD newborn screening diagnosis group and the LSD other, the clinical diagnosis group, we found that parents with children diagnosed with LSD or ALD through newborn screening had lower rates of depression and stress. Upon logistic regression, there they go. So you can see the difference here. So 71% compared to 35 on the left-hand side is the depression, and 66 compared to 40 on the right-hand side. The logistic regression shows us that when comparing the LSD other diagnosis group compared to the LSD newborn screening diagnosis group, we find that those diagnosed clinically were 6 times the odds of having considerable depression when controlling for region of the US, race, and income. So those were found to be highly associated on that first analysis. When we look at parental stress, we see that that same group was almost 3 times the odds of having a high parental stress score compared to those diagnosed at newborn screening, controlling for a different variables here. We were also interested in comparing the difference of parents of children diagnosed with the routine RUSP disorders compared to those with LSDs and ALD through newborn screening. Is there a difference there? And we did see that, right? So we found that the parents had, again, lower odds or lower rates of depression and stress in the LSD newborn screening group as compared to those in the RUSP routine screening group. And here we're seeing that parents in the RUSP diagnosis group were about 3 times the odds of having considerable depression and almost about, and again, 3 times the odds of high parental stress. We found a significant association on the depression side. So there's stars here. The threshold on the parental stress almost made it. We're trending in the same space, but it didn't meet significance, but it is still important. So overall, the study suggests that parents who receive their child's diagnosis for one of these disorders have lower odds of depression compared to parents with children diagnosed with these disorders through family history or clinical presentation. A similar pattern emerged for the stress side, but didn't reach significance. So, the presumptive harms of screening newborns for potentially later onset conditions may be significantly less than expected. Maybe newborn screening reduces the diagnostic odyssey, and it enables more control of the child's health at an earlier stage. There's always limitations in the work that we do. Some of that is our sample size is small, so 174 split across 4 groups, comparing them, it gets really hard. So that's one thing. Also, our demographics, they're not very diverse, right? They really are hitting a representative of mainly patient advocacy groups has been reported. So high education, mainly white. We need more diverse samples. Also, the quantitative surveys don't tell us really the nuances of the experiences that you guys have, that families have. It doesn't get to that. It provides us some insights, and it's valuable, but there are ways we need to keep going. And also, there was no information collected about the quality of interactions with healthcare providers and how the results around communicating that and the experience that families have when that occurs. So overall, this data supports the need to keep going, to collect and obtain empirical data so that we can modernize and continue to have an ethical justification to continue to expand newborn screening. So where are we going? Where we've gone is we've gone to Screen Plus. And within Screen Plus, I'm bringing up ethics again before I touch and move forward. There's more debates. There's always debates. So we're on this cusp of transforming screening, newborn screening, We're continuing to expand our conditions that we can screen for. We're pushing for whole genome sequencing at birth. And there's a lot of debate, and I'm not sure many of you may already know this and have read the stories about the use of dried blood spots that are held in the state labs. Why is my baby's DNA being held by the government? I didn't say that you could have that. So, what do families want? We need to understand so that we do not get stuck in a situation very similar to what's happening in Michigan. Families brought a lawsuit against the state saying you are unlawfully holding our DNA, our child's DNA, right? But this DNA, which is a dried blood spot card that is de-identified and stored, is imperative to be able to continue to screen for one, the conditions that we already are screening for, but also to make sure that as we continue to expand, that we're doing the right thing, that we can test, that we're screening appropriately, that we're developing proper cutoffs, that we can develop new tests. So we need to understand, what do parents understand about these things? And how can we make sure that what we do is transparent, it is ethical, and that we have the stakeholders on board so that we can make sure we can keep going in the work that we do. So Screen Plus, it is similar to the pilot LSD study, but it is bigger and hopefully better. It's run in conjunction again with Joe Orsini and the New York State Department of Health. We're enrolling babies at 9 pilot hospitals now, and you can see them on the right. We're assessing the analytic and clinical validity of these assays for a fluid panel. Right now we're screening for 14 conditions, and depending, we have specific criteria for disorders to be able to come onto our panel. There's an early onset form, there is a path to treatment, and we can screen for them in a multiplex manner. What we learned from our prior pilot is that the LC side, the ethics, the legal, the social issues, we need to integrate it throughout our program so that we can pick up and learn from the parents that we interact with from the get-go. So here's our LC structure. On the right-hand corner is Dr. Aaron Goldenberg. He is our bioethicist and co-investigator on this study. We have really 3 buckets here that we engage parents at. The first is during the consent visit. So our pilot program is consented and prospective. We have coordinators at these hospitals who interact with new families every day. They just gave birth, they're talking about newborn screening. And in that time, they can choose or choose not to consent and enroll their baby in the study. At the same time, we ask them, would you like to participate in LC? Regardless if you participate in the screening side, we want to hear from you, right? So how was that consent process? Did you have enough information? Why did you make the decision to participate or not participate? And collect sociodemographic information so that we can see, are there differences broadly in how people approach making decisions and the type of information they have? And can we do better, right? We get feedback and we say, oh, our brochures didn't say this. Let's tweak it and let's make it better so that we're making sure that everybody has an opportunity to understand what we're telling them. On the quantitative survey side, so after newborn screening result is finished, we're sending out flexible surveys, meaning we can develop multiple surveys and we can send them out to participants as we have them or as we complete them, and we'll send them out. Right now we have 4 surveys that are already developed and 2 we're about to pilot next week. So expanded newborn screening program policy, dried blood spot research, and whole genome sequencing. At the end of this spectrum, we have qualitative interviews. This is where we get the nuances. This is where we get your stories, your experiences. And this is approximately 6 months to 2 years after diagnosis. So as I said, the parent perspectives on the future of newborn screening, these are like our hot topic surveys. We're going to email them out. We hope to have thousands of respondents, and they're currently available in 10 languages. And again, so when we look at expanding conditions, what types of disorders should be included? Is there a limitation of age? So how comfortable do you feel with early onset? Well, how about when it's kind of maybe adolescent or maybe later in adulthood? What about treatability? When and what impacts parents' opinions around treatability, diagnostic and prognostic uncertainty? We know we found something, but we're not yet sure if we know if your child will develop it or when they need treatment. On the newborn screening benefit side, we're asking parents to not just think about my baby, but to think about the system. So how do you now view screening every baby for conditions that are expanding, right? With the same kind of framework, age, treatability. But we're also asking about reproductive planning, future planning, relative risk, so the risk to other relatives. Dried blood spot storage, I talked a little bit about this before. So do we need consent from parents to store and to use the dried blood spots? Who do they feel comfortable using it? How do we use it? How much do you trust certain entities? Do you trust academic researchers, pharmaceutical companies, your healthcare providers? And then finally, on whole genome sequencing, also another trust thing here, but also privacy. We have a lot of data now. Genome sequencing is going to provide a lot of data. Equity and diversity is huge across every aspect of the work we should do. But as we push for newborn sequencing, it's going to should be another issue that needs to be at the forefront. What information should be returned, actionability versus non, and should uncertain results be shared? So finally, our qualitative study on the parents' voices of newborn screening. We hope to generate the knowledge about the emotional and social impacts of receiving positive and uncertain results. We want to understand how the newborn screening system can better meet the needs of families. So patient-provider communication, support resources. How do you cope with uncertainty? So our eligibility criteria here is you must live in the United States. Again, English and Spanish speaking for now. And you have a child who received a positive or uncertain diagnosis, either a screen plus or a RUSP disorder in the last 6 months to 2 years. Eligible parents can come to, we'll reach out through different channels. We haven't yet started, but soon, we're hoping this summer. And we'll ask them to complete a brief survey, demographics, distress scales, so we can get a baseline measure. Sorry, too close? No, too far. And then we'll have structured interviews for 1 to 2 hours. And with that, I will leave you with that. It's critical to obtain this data. We need to understand the existence, the severity, and the endurance of potential harms for complex disorders. Is it me or is it you? Especially as we can approach this genome-based era. Parents, you are our stakeholders. We couldn't be here without you. You can see from the talks and the conversations before we went to lunch, we need to hear each other. We need to understand that there are so many impacts of how communication is sought. There are many different ways that parents will hear them. We need to hear all these voices. We need to hear all of your voices so that we can better understand and quantify where do we go? How do we better support each other in the work that we do so we can continue to move forward? And with that, I'll leave you with my acknowledgements. We have a large team, and feel free to reach out to us if you have any questions, collaborations, ideas, thoughts on survey, anything. And thank you.
Hi, thank you so much for that. I had a question as far as, do you have any data? And I know that Screen Plus is still new, but any data on how many parents have opted in to this?
Into LC or into the pilot?
Into the pilot.
Into the pilot, I do. So far, ramp up has been slow. It is a massive program. So regulatory, clinical research is hard. You have bureaucracy, you have regulatory. Right now we've enrolled over 6,000 babies. So we're now at 7 hospitals. It took a little while for us to get all of the pieces together across 9 just hospital sites, but also all of our funders and contracts. So we're now almost there at full speed. We should be enrolling around 2,000 to 3,000 babies right now, projecting a month. And of that, almost 80% of parents are interested in the LC.
So 80% have opted in for Screen Plus for the pilot?
No.
No.
80% of those who've enrolled in Screen Plus pilot study have also opted in for the LC surveys, so the ethical work. Our percent right now of those who are opting in to have their baby screened, of those approached and have discussed and made a decision, is 60%. It's actually lower than what we saw in our previous pilot. And what we're learning from our feedback surveys is that privacy is a huge thing. People are concerned about what we're doing. What are you doing? I don't want my baby involved in research. And also, a lot of families now have expanded carrier screening prenatally, and they feel like, I've already done this. I don't need to do this again. So the data that we're gaining is going to be vital for us to understand, well, why is it different now than it was 5 years ago? So, yeah.
Thank you.
You're welcome. Okay.
Okay, thank you. That was such an important talk. When when I put my slides together for the legislative updates, I had started a slide for the dried blood spot, and I didn't have the courage. So thank you so much.
I know.
Because it's such an important part of all of this. And when people are only reading headlines, it's not a good way to educate yourself. So you did a great job on that. Thank you. There's a question on Zoom, which I was also wondering. The question is, how can we sign up? So we have a very motivated parent who, do you have to be in Screen Plus to take the surveys? Is there a way, if you're just a part of this community, that you want to contribute your experience?
That's a great question. So right now, sign up for which, right? So the survey side right now, we're only enrolling people we interact with during the consent process for newborn screening. But Melissa and I, Dr. Wasserstein and I have been talking about, once we get the pilot out, right, meaning these first 2 surveys and the infrastructure built, which it is now built, and we're about to test it, we're looking to expand, right? Because it's not just the new parents. We need to hear from all types of parents about these opinions. So that's our next step on the LC side, or on the survey side. And so what I'll make sure to do is, Miranda and Elise, once we have that move to push it out beyond, I'll let you know. On the qualitative side, if you're eligible, and once we enroll again, we'll hope to inform, and you guys will be informed, right? PAGs, or patient advocacy groups, are important. Care providers, you will also very important. We'll let you know so that you can offer it to everybody. Okay. Thank you.
Thank you.